My name is Heun. I'm a consultant psychiatrist and editor of Global Psychiatry Archives. Today I want to continue our series Mental Health Explained, and today I'd like to talk about social phobia, or what they call also a social anxiety disorder. And the principle is that there are symptoms of extreme anxiety, which is psychological and also physical, autonomic, and it's not related to OCD or other delusions or schizophrenia. It's about social situations. That's why it's called social phobia. It's maybe the anxiety of having a conversation, talking to others, eating or drinking in public, or being in public. And there is then this desire to escape or avoid these situations, and which then relate to the feeling of being inadequate. In the epidemiology, you find that the lifetime rates, depending on the criteria, are between 2 and 12%. That's a lifetime, what means, at least it appears in every one, whatever, 2 or 12% in the life, at least once for a period. And that's a criteria, lifetime prevalence. If you have 12 months prevalence, so that's, it should be happening in the last year, so usually have 6 to 7%. Usually you have a higher rate of females, but that's usually sometimes a bit different. In some studies you find that male have more problems, but there isn't any consistent finding. The distribution can be in early childhood, but some experience the social anxiety only later, when they have possibly a new job or having something to experience which they haven't experienced before. There are some genetic factors, usually examined by looking at the difference between monozygotic and dizygotic twins. So let's say if the prevalence with dizygotic and monozygotic twins is the same, then you would expect that the genetic twin, the genes play a very limited role. If the rates are much higher in monozygotic twins than in dizygotic twins, then you would expect, that the genes play a higher role. Anyway, right, okay, so what you see is that, the etiology is not totally clear. Some people, as I said, genetic factors play a role, but other factors like learning and inadequate learning in the family might play a role. There are imaging studies which say there is an extensive response of the prefrontal cortex, or the amygdala, or the hippocampus during anxiety-provoking tasks. So the question is this an epiphenomenon or is this a cause? It's very, very difficult to know. The fact is that antidepressants play a role, and if antidepressants play a role, people very often would say that medication, or that this is caused by, let's say, different or whatever, lack of specific neurotransmitters playing a role. But that's a bit of a tautology. If you say, okay, medication works, then you would say, oh, this is what the medication does, is something what works and which is caused. But that's not the case. You only know the medication works and you don't know how it works. And if the medication does something in the brain, which is always doing, that might or might not be the cause of the disease. It might be that the fact is that the medication affects the phobia, but also has an effect on the pharmacology in the brain, or the pharmacokinetics, or the effect on neurotransmitters. But you wouldn't know that whether this effect is related or is it something completely different. Right, okay, so sometimes it can be trained. People have somatic symptoms like blushing, trembling, dry mouth, perspiration, excessive fear, fear of humiliation, embarrassment, or others noting how anxious they are. So that's anxiety of showing anxiety. People might be very critical to themselves. They avoid situations that may lead to difficulty in maintaining social or other relationships. They might lead to educational problems, difficulties in interaction with other students, or other people, teachers. They might later lead to job problems, and people might perform or might prefer to work in jobs where they have less responsibility, or where they just maybe are more in the background. So let's say that way, people might work in an environment where they don't have to speak with other people at all. Right. Lots of comorbidity with other anxieties like agoraphobia. People might have other simple phobias. Panic disorder might be a problem, or secondary substance abuse, as you might be aware from previous talks. Depression and anxiety often go hand in hand, so anxiety might be a problem. Usually when the anxiety is something which is in the forefront and where we have this social phobia, we call it social phobia. And on the other hand, if depression and anxiety might be general, we might call it anxiety and depression, mixed anxiety and depression, or other diagnosis depending on the comorbidity. Right, the management is usually CBT, so anxiety management, talking about anxiety. Then there's some components of relaxation training, managing the anxiety and the response to anxiety provoking situations. That sometimes goes with slowed exposure methods. Some studies, like the study or the research group in Marburg sometimes have something like flooding, where people have to experience very anxiety-provoking situations one after the other, and that sometimes leads to the fact that people can cope with other minor problems. Right, so usually if you want to deal with the effects of the situation, beta blockers might stop the excessive heartbeats. There's benzodiazepines, which can make people calm down, but on the other hand, they're quite addictive. Antidepressants have been used, like SSRIs or SNRIs, that's selective noradrenaline uptake inhibitors like venlafaxine. Monoamino oxidase inhibitors have been used, and reversible monoamino oxidase inhibitors like moclobemide have been helpful. In some cases, if this psychotherapy approach of CBT, cognitive behavior therapy, doesn't work, a psychodynamic approach can be used. Psychodynamic is more or less, talking about the situation, the life, and is much less structured and doesn't give tasks. It's more or less about talking the situation, the life, the failures, the good, the bad, and seeing how people can integrate or can overcome the anxiety and have a normal and more happy life. Usually, if the treatment is well performed, CBT works very well. Social phobia might get better. Without treatment, it's usually a chronic disease, sometimes lifelong. However, if that's possibly well treated, 90% get better. And especially in most studies, it's shown that a combination of CBT or psychotherapy and medication works best. So that's most of what I wanted to say about social phobia. Can be very debilitating, and it can be treatable. And I hope that with this type of talk we increase what we call mental health awareness, and that people learn to deal or to recognize diseases, avoid stigma, learn to support patients, and do the right thing going to the doctor or finding a psychiatrist. Thanks for your interest, and if you want to hear more of that, just enjoy our website and the channel Global Psychiatry Archives, and I wish you a nice evening. Bye-bye.